Sure. Yeah. Thank you so much. Welcome everyone to the nursing session for the month of June 2025. I sincerely thank Pony ma'am and her staff nurse, Nancy, for agreeing at a very, very short notice to do this session. So, in the next 40 to 45 minutes, they'll be talking to us about the role of nurses in the bone marrow transplant unit. Of course, they are the most crucial and integral part of the unit without whom we can't claim any credits. So, without wasting much time, I hand over to Pony ma'am and her team to start the session. So, I request all the delegates to post their comments and questions in the chat box. We'll take up at the end and discuss. Thank you so much.
Thank you, Dr. Dharni. We've just merged both talks together, but I'm going to let my lovely BMT nurse, Ms. Lancy, to talk first about a case study, followed by a discussion on the role. Thank you. On to Lancy.
Hi, good evening to all. Thank you for giving me this opportunity. I am Lancy. I am a pediatric BMT nurse working in Clinicals Hospital in Chennai. And here to present about role of nursing in BMT through our case study. I came across 15 years old girl, Miss X's, who was diagnosed with chronic myeloid leukemia in Jan 2023.
Next slide, please, sir.
She was started on TKI and monitored with BCR and ABL. Unfortunately, February 2024, she developed the myeloid blast crisis. In March 2024, she was then initiated on nilotinib and started chemotherapy to treat her acute myeloid leukemia. After that, first cycle of chemotherapy, her marrow was remission and BCR-ABL was major molecular response. Then following second cycle of chemotherapy in April 2024, she prepared for a bone marrow transplant matched sibling donor who was younger brother. But to give a little background, she was always being very anxious teenager and entire family throughout the treatment course and escalated in February 2024 when she was developed myeloid blast crisis. Next slide. We did few steps to prepare her transplant in pre-transplant nursing care to give psychological support to her and her family and also supporting to donor and ensuring a smooth the process throughout. So initially to prepare the parents and sibling undergo the transplant process. So we exposed the family transplant department and nursing team. Then the second way, priming the donor and constantly engaging the younger brother. So priming help for the procedure, multiple section of counseling, ensuring the undergoing the procedure and with complete consent, with donating the stem cells. We show demo pictures with stem cell collection, video of line incision for the procedure to the donor, and fitness was obtaining, including consent also. Next slide, please. The causes in BMT. We did conditioning with based busulfan, Ancyte, and RATG. She had BU-Psy and RATG, and we monitored the busulfan level also. So she had few complications. First one, fever on day -3 with RATG infusion. However, we taken blood culture and we did IV antibiotic also, and proper line care we maintained with aseptic techniques. She also had hypertension to start amlodipine and clonidine from day -6. She had lot of vomiting, so she had refractoriness to multiple antiemetics. We administered the antiemetics including lorazepam and did not work. Then we changed the olanzapine. Finally, it worked. We provide comfort measure and we also communicated with doctors about her compliance and effectiveness of her treatment throughout the vomiting period. Please change the slide. and ensure the adequate hydration, nutrition, and maintain also. And other complication, she had mucositis, then developed the severe mucositis also. Please change the slide. Yes, Meena. So already we inserted NG day 0. She had worsening oral intake, maintain and monitor hourly basis. She had severe pain due to severe mucositis, required even IV fentanyl infusion to control her pain and symptoms. Also, she had diarrhea. So, we did stool culture, including stool float Clostridium difficile and Clostridium difficile was positive. Then, infection control protocol was followed, and patient and attender stick isolation and stick hand washing ensured with reverse barrier nursing. We also applied protective wear and started in injection metro and she responding to treatment. However, he developed bilious vomiting and diet continues NG drainaging and gut rest also. So nutrition is the main problem. However, manage give a very low dose of parenteral nutrition throughout the course, and we also started TPN also to support the nutrition. Her bottom of lot of raw areas. So to treat it with zinc cream, hydrohyl gel, lignogen gel with hygiene maintains and cis bath also. Please change the slide, ma'am. And she also developed unfortunately complaints of VOD. So she presented with rising bilirubin during the period with platelet refractoriness. She also had third spacing of fluid. She also putting on weight. So worsening of kidney function and ensure the stick input output monitoring and maintaining the fluid balance to near the neutral. Fluid restriction was followed and also given 20% of albumin and also he followed give her injection methylprednisolone for 3 days to reduce the inflammation gradually started improving. So in nursing care here, very important to monitor the fluids and weight and we ensure that every flush was given minimal and every medication in minimal dilution. So she also had hemorrhagic cystitis. She is very struggled with hemorrhagic cystitis, needed more fluid, however, SOS and less fluid restriction. So she had hematuria with dysuria day plus 4 urine culture taken and she had adequate hydration and maintained a good hygiene. Please change the slide now. And slowly hemorrhagic cystitis improving and our treatment protocol which include sulfonamide, sodium pentosan and cipro also. And next thing upper gut GVHD. So she also developed vomiting, hematoemesis, which continued after period of engraftment. Initially through could be enterogastritis, supported her blood and platelet transfusion also. But potentially we ended of treatment her if possible mild upper gut GVHD with oral budesonide. So she also some gut rest and she had very slow introduction of NG feeds but started gradually is improved. Then patient finally discharged on completely enteral nutrition and oral budesonide and routine medication. Please change the slide now. Then psychosocial issues also major things. So we also accept she had lot of reluctance to take medicine orally, even intravenously also. We also involved patient in multiple activities like dancing, singing, art and craft, which elevated her mood. Anxious mother with distrust towards the medical fraternity. Nursing team with doctors had multiple discussion with mother to make her understand the process and the iteration of the BMT complication. On multiple section of psychological counseling we helped. Please change the slide now. And so finally, so after the child, right now she is to present the case study. Thank you. Thank you all.
Thank you so much, Nancy. I think the second part of the talk is also in the same presentation. If you could just share the slides again. So as you can understand, so this picture is actually a picture of a team, but the last picture on the right is the girl who she was presenting about. This is with permission that we've put up a picture. So as you can imagine, there's a very complex situation, very complex patient, having multiple needs, etc. And this is typical of a stem cell transplant patient. So thank you everyone for giving me the opportunity here to talk about the role of nurses in hematopoietic stem cell transplantation. I'm Dr. Ponni. I'm a senior consultant in pediatric hematology, oncology, and transplant at Gleneagles Hospital. Next slide, please. So definition of nurse is very much different from a definition of doctor. So if you look at Oxford Dictionary or Cambridge Dictionary, the definition of doctor will say that it's anybody who can treat an ill person. So treat is completely different from what you do. You care for the people. It's a holistic care. So definition of nurse here is a person whose job is to care for people who are ill or injured, especially in a hospital. As you can see, just beneath, I've just mentioned what care means. It's providing the needs of someone. So understanding what their needs are in a holistic way and providing support. And that's a nurse. That's something very noble that I don't think a lot of doctors will be able to even do. What a nurse could do. So we always appreciate your job and we're grateful for your job. So we could do a wonderful job on site. Thank you. Next slide, please. So at the end of the talk, I just want you to understand how complex the needs of our patients will be in a stem cell transplant unit and how different a role you can actually obtain as a nurse. It keeps changing. It's quite dynamic in a stem cell transplant unit, and also to sensitize about what is the future for you as a BMT nurse, evolving role of nurses in the future. Next slide, please. So just a couple of slides about stem cell transplant process and the complications. Next slide. So next slide, please. What are stem cells? Stem cells are nothing but they are cells which can actually repopulate or regenerate itself and also will be able to differentiate into multiple cell lines. So here we are interested in hematopoietic stem cells. Hematopoiesis is nothing but blood forming. So hematopoietic stem cells are the factory which produces blood and it will also be able to regenerate itself. Next slide, please. So, looking at the function, it can, like I said, one single stem cell can regenerate more stem cells. It can also differentiate to form all different types of blood cells. Next slide, please. So why do we do stem cell transplant? Not everybody needs a transplant. Not everybody who's coming into a hematology or an oncology ward will need a transplant. But there are certain indications. So there are defined indications and sometimes indications keep changing. Varying. So mainly a transplant is done where if a patient has a defective bone marrow, which will not be able to produce enough cells or dysfunctional blood cell, etc., will be able to replace its missing function. Or sometimes in the event of a patient with cancer, we might be able to give high dose chemotherapy, eradicate all the extra leukemic cells or any other residual cancer cells. And then once the bone marrow is completely ablated, we might be able to infuse stem cells into that space and make it functional and cancer-free. So this is why we do a stem cell transplant. Next slide. Next slide, please. Yeah. So as you can see, there are different phases before a patient walks into the transplant unit. And as a nurse, you do fill in a lot of these roles. So the first phase is the pre-BMT phase, followed by a BMT, and obviously a post-BMT. In a pre-BMT, it starts at the time of diagnosis. So when a patient comes in and gets diagnosed with, for example, a bone marrow failure or a leukemia, who could be a very high-risk leukemia, not responding to treatment, etc., it starts there. Once you start talking to the patients and saying that a transplant could be on the table for this diagnosis, it starts there, and you have to start preparing the patient then. The second thing is, yes, is there a definite indication for this patient? And if there is a definite indication, is there a donor? And you start identifying a donor and then prepare the patient. And if it's a related donor, you prepare the donor as well. Ensure that it's a completely informed decision that they're making along with the family, and treating the disease as a whole with bone marrow transplant. So the nurses can fill in a lot of these roles by counseling the patients, sitting with the medics, giving them support. A lot of times, if you've watched consultants, counseling patients when they come in for transplant, I do take like an hour and a half to 2 hours to sit and counsel a patient. And a lot of times we do wonder if they don't cry at the end of the counseling or midway through. It just means that either they haven't got it completely about the complications of transplant, etc. Because a lot of complications we talk about is very heartbreaking. It doesn't mean that the child is definitely going to go through all these complications, but it hits them hard when they come to that point that we talk about BMT, which is going to be the next phase. And this child might have a potential risk of a lot of complications, including infertility. Even hair loss is a big thing for a teenager or a young adult. Second, cancer. So we're dealing with a child with a leukemia who's going to go for a transplant. But then we talk about the risks of second malignancies 10 years or 20 years later. So all these are difficult conversations. As a medic, we can just come talk and just sometimes just leave the patient with a thought. But a lot of emotional support, organizing, stem cell collection, preparing the patient and the donor is all done by nurses and nurse coordinators. The next phase is BMT. BMT is when the patient comes into the department and you get them admitted, and they go through the entire course of transplant. You do give them conditioning, you care them for by giving them the chemotherapy, relevant chemotherapy, and possibly a radiation if needed. You also deal with the immediate complications during the chemotherapy, conditioning chemotherapy, or after until the time of engraftment, sometimes even beyond engraftment. Like this child who had, VOD, and then she had mild upper gut GVHD. We had to keep her in for a longer time than we usually would do because we had to focus on her nutrition. And mainly all these were cared for by our nurses who made her better at the end of the day. And post-transplant, course like late effects, relapse, second cancers, and infertility. A lot of times it hits them hard again when they come in for follow-up beyond 1 year of time. And that's when we start talking about late effects. And as nurses who are doing clinic sessions with us, there's a lot of discussions with the family. Sometimes even they come up with questions like, oh, can she even get married? Can she have a normal life, relationship with the husband? Can she bear children? Can she look after, a family, etc.? Lots of questions do come through, and sometimes lots of parents will have a lot of hesitation or reluctance asking doctors these questions, and they feel much, safer and easier and accessible with the nurses who have developed a long-term rapport with these patients and families. Next slide. So this is in brief about, when they come in for a transplant and they get admitted, what is a pre-transplant period? It is the time when you're conditioning the marrow. And early post-transplant period is until the time of engraftment or until the time of discharge. And next slide, please. And then there is also a late effect or late post-BMT period. Next slide, please. And the next slide. Thank you. So I've listed some common complications that you might have, seen or managed patients. So these are just, a few of the complications. Sometimes not all patients will follow textbooks. Sometimes they come in with a rare of rarer complications too. And it's even more harder as a nurse when they deal with much rarer complications to reassure parents, because it's not that common. You don't see that often, and we don't know how the outcome would be, etc. And sometimes it's much challenging than what is listed. Next slide, please. So how do we treat this complex patient? So it's a teamwork, basically, with patient in the center, and physicians, nurses, and allied healthcare professionals will all have to work hand in hand to get the patient better. Next slide, please. So what is the role of a BMT nurse? Many, as I said, very many. And as you can see, we always shout for, oh, sister, can you come here? Can you do this? Please, urgent, blah, blah, blah. And then as you can see, you even if you have 6 or 12 hands, it's never going to be enough, because you're there next to the patient who needs 4 or 5 infusion pumps next to them. And look after the bottom care, doing sit spat for this child, getting everything cleaned, and then doing line care, line dressing, hooking them up with a TPN bag. And then there is the mother sitting in the corner and crying because she doesn't know what is happening, and counseling the parent, and also doing all this art therapy and singing and dancing and getting them cheerful and having a positive attitude. So it's never enough. What you do is what you feel, but we are all very grateful for whatever you do, because we do understand these patients are very complex and they need a lot of care. Next slide. So with the patient in the middle, the different roles that the nurse can actually fill up is, they could be a caregiver. They could sometimes even be a primary caregiver if the mother is not well, or sometimes it's too much for the mother. You want to give the mother a break and ask them to go away for a day and sleep in their own bed and come back the next day. Sometimes you're the sole caregiver, without a rest or something. You would also, actually, a lot of times you don't understand that you've also been a counselor for them, doing psychosocial counseling for this family, educating them about, medications, importance of compliance, etc., recognizing complications at the earliest and letting the doctors know on time that I'm suspecting whether this patient is having VOD, because we've been giving SDP on a daily basis. The child is having platelet refractoriness, is a VOD. We've had nurses who just look at the stools and say, I don't think this is infective. This looks like a GVHD stool. So that's how experienced our BMT nurses are. Sometimes they take on the research role, because when we're stuck with the complex patients, many brains start thinking and saying what we can do better. And sometimes there are lots of trials and studies coming up, and nurses do take on a research role too, conducting trials. Coordinating care is always the most difficult job. Getting 2 teams together and look after one single patient is not very easy. But coordinating care, just to get the patient better, like even with a dietitian or physiotherapist, and getting them all to work together, is also your role, which we've seen many times happening. Infection control, very, very essential, because one of the most common complication, and which can also be the biggest problem which we deal with, and can also affect the outcome, is infection. So infection control is something that you do diligently, and assessing nutritional needs for each patient, and having a care plan for each patient. Next slide. So in the pre-transplant period, as Lancy was mentioning, there are different roles that you do. Next slide. One of the first thing that we do, next slide. One of the first things that we do, or the nurses do, is patient education. As we just talked about, reiterating all that we've explained during the consent process, educating the transplant, educating the family, the patient, and the donor, age-appropriate discussion with them about the transplant process, what they're going to expect today, what is expected in the next day or two. Never easy to actually identify what's going to happen. If at all we have a crystal ball, we'll be able to tell what's going to happen. But anticipating certain issues, like if you're going to hook the patient with ATG, always tell them, well, this is ATG, it's an antibody, and this is going to go really slow. We're going to give some pre-medications. Despite all of this, a fever can occur, blood pressure issues or heart rate changes can occur. So we're going to monitor quite closely and quite frequently. Don't get agitated, etc. And it can calm the patient down. It will reduce the anxiety. As Lancy was explaining, that family was very, very anxious and hyper anxious family. But every single time, the nurses handle so beautifully well, explaining the entire process, the potential risk, and the care that needs to be done in every step. Next slide. Then comes a medical assessment. So as medical assessment, ensuring that all the relevant blood tests and imaging are done and looked together before fitness for BMT is done. Next slide. As a nurse coordinator, a lot of fitness is done by the nurse coordinator, and highlighted abnormal values to be discussed with the physician is done by a nursing coordinator. And those are brilliant jobs, which we've seen nursing, care at their best. Infection prevention is the next important thing, educating or preparing the patient and the family about infection prevention, like infection control practices that you do, what kind of a HEPA filter, how HEPA filter and positive pressure rooms will help reduce infection risk, what are the anti-infectives that we might be using as a prophylaxis setting, and exploring if the patient ever had any previous infection, any antibiotics or antifungal the patient had previously been on, or any positive cultures, and ensuring that hand hygiene policy is strictly maintained, and teaching the patients and the attender about all of this. Also educating them about avoiding high-risk areas, not just before pre-transplant, also post-transplant. It's quite essential because, as transplanters, we do see patients sometimes that they're not compliant, not understanding that they have to avoid high-risk areas, come back with a flu. And we've seen detrimental outcomes following that. Next slide, please. Nutritional support, very, very important. As a part of nursing care, it's a pediatric, in the pediatric setting, we do what we call it a stamp, assessing the patients and understanding whether they'll be at high risk of malnutrition or not. Every patient walking through the doors in a BMT department are high risk. So doing regular nutrition assessment is absolutely important, and optimizing nutrition. And also understanding what is neutropenic diet, and ensuring this is also taught to the family pre-transplant so they can be prepared during the post-transplant phase 2. Next slide. And a huge support in the psychological aspect as well. Every time the patient and parent, I always say the physicians come and go. We come, do the rounds, and we have a plan, and then we come back in the afternoon or in the evening, just making sure everything is done, follow the bloods, etc. But 24/7, the patient and the parents are looked after by the nurses. So they, they fill in a very huge space in the care, and majority of them are psychological support. We've also had nurses who, once all the IVs are done, etc., we've had nurses who sit next to the patient with a chair. They pull up a chair, sit, hold their hands, and talk to them, and that reduces the anxiety level so much. A lot of their symptoms are actually based on how anxious the patients could be too, like vomiting, refractory vomiting to antiemetics. This could help quite a lot. Next slide, please. And with regards to medical management in the pre-transplant period and also in the post-transplant period, is making the patients understand that they're going to be on a lot of medication during the transplant, and also understanding that they could have drug interactions, and involving the clinical pharmacist to check for any drug interactions. The patients have already been on medications. like getting the reconciliation form done, ensuring that there are no, do we have to continue these drugs? Do we have to stop the chelators before the patient comes in for transplant? The timing, educating the parents about the timing, etc. Throughout. Next slide, please. And finally, coordinating with other teams. As I said, it's a holistic care, and mainly it's done by the nursing team, including when the patient is getting discharged from a transplant unit, coordinating with other teams and ensuring all the needs are ticked off and we have a care plan written up. Next slide, please. So during the BMT phase, again, how does a nurse help in looking after these patients and getting them better? So thorough monitoring and regular monitoring and assessment. Obviously, we do vitals regularly on an hourly basis and do it on a Pew score, recognizing early signs of complications and letting us know so we can manage them better. Do we do regular blood tests on a daily basis or, alternate days, etc., doing regular drug levels. Importantly, infection surveillance, like looking for viral infections or viral PCRs are important. One more important thing is pain management and monitoring. Sorry, can you hear me? Pain score is something that we do log in. We encourage nurses to log in. So when it comes to a patient developing mucositis, etc., we'll be able to understand how bad the pain is despite giving them analgesics, etc. There is also a role for nurse control analgesias, NCAs, for patients, and we've used it at times for our patients. Which works beautifully well for very severe mucositis or very, sore raw bottom. It's a wonderful way to control the pain. The next important thing, as I said, again, reiterating infection prevention, ensuring line care is done very diligently and strict isolation precautions are done. Nutritional assessment, as I said, regular stamp to be done, which is to identify high-risk patients and if they're ever getting better, or do we have to escalate or de-escalate, the nutritional support, and always define a care plan for every patient. We also use NG tubes. The nurses do it on day 0, usually, anticipating that mucositis can set in, and it's quite difficult after that. It's important to prepare the patient and the parent about the importance of NG tube, not using it as a threat, because often the parents use it as a threat and say, if you don't eat, you're going to end up having a nasogastric tube. And they fail to show the importance of NG tube then, because as much as we have parenteral nutrition available for our patients, it's always better to use enteral nutrition as much as we can. It aids early discharge. It aids, it reduces the chance of infection with minimal line handling, etc. So it's quite important that you do teach them that NG tube insertion should not be used as a threat. And monitoring stool output and vomiting on a regular basis. This is a Bristol stool chart. I'm sure everybody uses the same, which will tell us whether we should suspect something happening like mucositis or infection or anything, and strictly monitor for additional complication. Next slide. Again, medications. So invariably, patients will be on a lot of medications, including immunosuppressants. So importance of immunosuppressants and drug level monitoring needs to be told to the family. Sometimes when they get discharged and come back a week after to look for drug level, cyclosporin level or tacrolimus level or sirolimus level, whatever you use in your unit. Always important to tell them how it's given, when it's given, does it have to be timed? And when you come in, do you have to give the patient these medications or bring it with you? Bring the list of medications that the patient currently is on, ensuring that you educate them every single time. So at the time of discharge, you don't have to have one big, long checklist that you have to do in half a day, but educating them in a slow manner. Fluid management, very, very essential. Always maintain adequate hydration. However, if they do come across further complications, there could be times when we use more fluid or sometimes restrict the fluid quite a lot. Like, for example, if a patient has hemorrhagic cystitis, we would liberalize the fluid to ensure that there's no clot, etc. But at times of VOD, we would ask you to restrict the fluid, like, a crazy amount of restriction, but ensure you work with the clinical pharmacist and the doctor to see how you could actually attain a fluid restriction. Never hesitate to ask them. We'll always ask you to use smaller flushes during these times when fluid restrictions happen. Minimize the dilution. Sometimes some antibiotics could be given neat instead of diluting it and giving it 50 ml or 100 ml. So ensure that you do talk to your clinical pharmacist and get all of this done. So when we say, restrict the fluid to like 1,200 ml for a child, you cannot achieve 1,200 ml most of the times because they'll be on blood products and that will take up like 500 ml. But you'll have to figure out a way of how we can restrict the fluid as much as we can. Again, psychosocial support is very important. Despite all that I've said, I've always thought we need, the young ones, the young nurses, and sometimes even us as doctors, we all need to have a basic psychology assessment training done so that we can do a beautiful job looking after the psychology during the treatment course as well. There are countries where every nurse gets a basic psychology course. They do distress thermometer. They do look at the patients. Every patient has an individual care plan, and they work well together with the psychologist and the parents. So it's always important to actually consider sensitizing these nurses on basic psychology assessment and care. Next slide, please. And follow-up care. So when do you help or educate the patients about follow-up care right from the beginning? So ensure that at the time of discharge, you don't have to go through, like I said, a long list of checklist for discharge. But if you've already reiterated all that before, they'll ensure regular checks, compliance with the medications, understanding why weaning of immunosuppression is done, when it's done, understanding that these patients will need revaccination when their immunity starts to build up at some point, like at 6 months or 12 months time post-transplant. Some patients will also need rehabilitation at the time of discharge because of reduced mobility, because they've been on steroids or in bed for a month. Always ensure that they're mobile, even within the unit, whatever they can do, and try and get some physio exercises like stretching, etc. to be done. Next slide, please. So we do understand that these are just not the roles that you fill in. Like you can see, I've just given a little reference here underneath. You do a lot of clinical tasks and non-clinical tasks. You do equal amount of non-clinical tasks. Your hands are always busy with documentation too, despite looking after these patients. We have to keep checking medications and ensuring that it's the right dose, right dilution, etc. Ensure handover is given in a detailed manner, etc. And taking breaks. A lot of times we've seen nurses not taking breaks, not able to eat. They're on a long shift and they go home hungry, not able to come out of the BMT department. But ensure that you help each other and take regular breaks, etc. Next slide, please. So every unit works very differently, but you need to understand how your team works. Next slide. So with regards to every unit working differently, and you might face different challenges, but figure out a way that you can actually, find a solution for each challenge. Next slide. So coming to evolving roles of BMT nurses, so there is a huge potential for skilled nurses globally. So we've always found there is a high rate of attrition, not just with nurses, also with doctors, because they want to, skilled ones always want to go higher up and get more skills and learn new things in a different healthcare system. So there is an ongoing increasing global demand for skilled nurses. I think even recently there was a beautiful article written by one of the directors of Apollo Hospitals too about this, and we are so proud of it because everywhere people are looking for Indian nurses. And it's very important that we need to keep up with technology too. Artificial intelligence is coming up. So lots of nursing care, nursing documentation, handover, etc., is also going to be driven by AI. So it's important to keep yourself updated. And lots of hospitals have electronic medical records, and this is something, if you haven't, but that's something that will, keep coming into your hospital too in the near future. Also, a lot of follow-up care, regular follow-up care can also be done in a virtual manner and remote monitoring. And, clinic nurses would do a lot of remote monitoring, for example, like, maintaining records of how the nutrition has been, how many vomiting, stooling, etc., what is the weight, and there are lots of virtual consultation, remote monitoring that you could do with technology. So there are apps which can be developed, looking for compliance and etc. Then the other thing is how you can progress further. There are advanced nurse practitioners and nurse consultants where you're also authorized to actually examine the patients. In the West, they are able to even prescribe medications when you're nurse consultants and advanced as an advanced nurse practitioners too, which are all beautiful evolving roles. And, like I said, AI has come up in a big way, and lots of e-learning modules are available. You'll be able to obtain global certification and, also work through leadership roles. Next slide, please. So conclusion is it's very important to understand as medics ourselves, and you nurses also, pat your back and say with empowering nurses to be able to manage patients and, giving them best training, etc. We've had very better survival outcomes. We've always, looked back 20 years or 25 years back, and the survival hasn't been good. It's all been because of supportive care, medications, etc. Now we've got beautiful medications. We've got beautiful training modules available. And empowering nurses with a lot of this training will help, getting us better. And we also know that you fill in a lot of different roles in one person in the clinical setting. However, look beyond, and there is an expanding role in the leadership side too. Understanding that you work for the patients, we all work for the patients, and you have a major role in patient advocacy as well. You provide support, and you also look at patients' rights too. And, we're ever so grateful for all of that. Next slide. And thank you so much for being excellent superheroes in disguise. I'm sure if you haven't heard testimonials, but you should start asking patients their testimonials, and you would be awed by how much they appreciate. Thank you so much. Happy to take questions.
Yeah, thank you, ma'am. Thank you, Ms. Nancy. So that was a comprehensive session. I think I've covered most of the things. If there are any questions from any of the delegates, please post on the chat box. We'll wait for a couple of minutes.
Okay. Dr. Dharani, you have anything to add or say about
No, ma'am, I
roles?
think it was quite comprehensive. You have covered almost everything.
Okay.
I wanted to ask you, like, how, you know, the one-to-one nursing, are you able to, strictly follow up in the places that you practice?
Most of the times, yes, because we are actually a smaller unit. We're not, we're thankful again for that too. But a lot of times the challenge will be if it's a bigger unit, and with, sometimes some hospitals have very short-staffed, trained people. They have to do, it's very difficult to do one-on-one care. It is mainly for infection control rather than anything. But 1:1 or 1:2 is acceptable as long as we are strict with our infection control policies. And if the patient is not unwell, etc. But like I said, yeah, we've been thankful in one way that we might be able to manage. We have also encouraged mixed skills. So we have also, we've had times when we've had cardiac nurses or liver transplant nurses coming and covering. We've always encouraged mixed skills. So we try and train nurses beyond just pediatric hematology, oncology, or BMT. So, when it comes to crisis situation, we might be able to, raise a hand and say, can we have some, extension of help? So it's important for nurses also to understand that if they do like it, but they're working in a different area, never too, wrong to actually have a mixed skill set. So.
Yeah, completely agree, ma'am. Only thing, the confidence about uh, advocating the neutropenic care and the policy is very important. I think the nurses who are in the BMT unit should be more stricter than us who's actually in the bedside. So,
Oh, absolutely. Absolutely. I agree.
yeah. So I see many people thanking you for an excellent session, but there are no
Thank you.
questions as it is. So if there are more questions, I think they will hand over the session to Manisha for closing. Thank you, ma'am. Thank you, Puni, ma'am. Thank you, Ms. Lan.
Thank you so much, ma'am. And thank you everyone for this wonderful session and joining in. I have posted the feedback link. I request all the participants to just give your feedback for the session before leaving the session. Thank you so much. I'll give you 2-3 minutes. Meanwhile, you can submit your feedback.
Thank you all. Thank you.